Good morning. We're back 10 a.m. Wednesday. We actually got off on time like we wanted to. We're going to do a little more clinical this week. We're going to look at the TMJ and temporal mandibular dysfunction, which is what it actually is. Most people say they have TMJ. You actually have two of them because they're joints. And so we're going to just kind of overview how we assess the TMJ and then how we treat it. There's a lot of misconception out there as far as like conservative care of TMJ or TMD, I should say, that we're going to be thrusting on it, we're going to be manipulating the TMJ, when in fact we're not going to, because the TMJ is a very interesting joint. There's no joint like it in the body. It's actually a joint that lies in a fossa or a little hole in the occiput, which is the kind of the bone that supplies most of your skull formation. And then there's a disc with a bunch of what we call retrodiscal tissue that sits on top of that. So it's actually a little disc, a hole, and then the temporal mandibular joint. And the way it works is it has to actually move down and back and kind of swivel in this little not quite ball and socket relationship. But when it starts to compensate, or we have, there's a lot of lifestyle and stress issues that go into TMJ dysfunction or TMD with grinding, clenching. We're all stressed in today's society, it seems like. So there's a lot of underlying social issues that you also kind of have to work through, and we'll talk about that as we go through. But if you do have jaw pain or even headaches, a lot of the TMJ has a lot of neural activity. There's a lot of nerve input, a lot of mechanoreceptors, because there's so much movement that the TMJ has to have that it can do a lot of weird things. It can cause eye sinus type issues. It can cause fullness of the ear or ear pain. It can cause ringing in the ears. It can cause headaches. It can cause the top of the skull headaches. So it's one of those things that we need to assess when we're looking at neck problems and headaches, just to make sure and to rule it out, make sure it's not a player, and oftentimes it is. It's one of those things that just kind of gets overlooked. And anybody that has jaw pain or TMD, you know how frustrating it is. It's hard to find a good team to work with because it's somewhat misunderstood, and in the conservative world, it just kind of gets brushed over because nobody really understands how to assess it and then how to treat it. So we're going to use Dr. Peters here at first. So the assessment's actually pretty simple. The TMJ has to basically be able to swing down and back and just kind of stay in that little fossa and just roll and glide. But what we look for is disruption or some sort of dysfunction in that rolling and gliding, that down and back movement that we should see with the TMJ during mouth opening and closing. So first thing we do is we have the patient take and put 3 knuckles together, which is roughly 33 millimeters, and that's normal mouth opening. So if you have less than that, then we know that that's a sign that there's some muscle or joint restrictions. There's some sort of compensatory pattern that's going on around the TMJ. If you don't have full mouth opening, then that's how we assess it. Real quick and easy. We don't get out a goniometer or special mouth measuring device. We just 3 fingers together, 3 knuckles open, and if you can clear those 3 knuckles, then that's normal mouth opening. Next, we look at the function of the TMJ, just like we do with everything else in the body. We look at kind of kinetic chain, and we just see what mouth opening looks like. So we just ask our patients to open and close a few times, and we just kind of look at this from the side. And a lot of times we have to get over to the side so we can see if there's a nice level down and back movement of the jaw. If it stays out or if it protrudes or moves up towards the ceiling, then we know we have some muscular dysfunction going on and we need to address that. So we have some check marks that we make here and we just check that. Next, we feel for the motion, so we put our fingers right where the TMJs live, these 2 joints here, and we just follow it. We don't really care for deviations from side to side because those deviations are just more of the dysfunction, so we just kind of feel for the motion and we don't really concern ourselves with how it moves from side to side. We just want to see, can it move down and back? Like that's the primary movement for the TMJ. So we just feel, and they do that mouth opening again, kind of getting out of the screen there. Perfect. And we just note whether one side moves differently than the other. if we had to get really nitpicky with this, Dr. Peters, Jace here, his right TMJ doesn't move as well as the other. The other one kind of does exactly what it should. This one does not. So we would make a note of that so that we're starting to see a side of dysfunction, which is usually the case. We don't usually have bilateral jaw issues. It's usually one side or the other. Next, we feel for muscle tension in a muscle that should be doing most of the controlling of the down and back movement, which is, we call them the anterior digastrics because that's what they're called. So we can assess like muscle tension in an inhibited muscle or a weak muscle, one that's not doing its job, and we just kind of feel back and forth and note tension or trigger points in those muscles and the lack of motion or the increase in tension from one side to the other. And it usually correlates with the side that has less movement, or we see that kind of that upward or that outward movement versus the down and back, the immediate down and back movement of the jaw. Like they usually correlate. And then we just palpate the muscles here in the TMJ, and then or in the jaw, which is the masseter muscle, and then in the back of the skull where these little suboccipital muscles live, or the facial nerve, the suboccipital nerve. There's all kinds of interesting neural plexuses that come out of the upper cervical spine that correlate with the jaw as well. And then we just ask questions, whether it recreates pain that they've had in the ear, in the head, in the eye, those kinds of things. And we just make note of that because a lot of times it's just never been assessed. So we're looking at the function of the TMJ. And we're just making notes of what muscles we think may be tight. And then we basically attack our treatment based off those functional findings. So Dr. Peters is going to talk about that.
So we'll kind of switch gears here, we'll focus more on the treatment side of it. So let's say we'll just kind of focus, if Corey, just for the camera's sake, we'll kind of do this left side so you guys can kind of see what I'm doing. So we usually generally just treat the one side, the dysfunctional side. An interesting thing that we're not going to show you today, but 70% of TMJ issues, or the TMD, actually have a cervical spine component as well. That's why we feel as chiropractors we're very well equipped to treat these issues because we are the masters of the cervical spine. So all that is going to come into our treatment and in our assessment as well. In certain postures or positions, does that kind of cause the different symptoms to, like with protrusion, like Corey does, if we force him to do repetitive protrusion, does that make this worse? And as well as if we elongate his cervical spine and try to get him back into a more neutral position, does that relieve some of the symptoms? So generally what we start with for the treatment is we're going to kind of palpate the side to side and kind of find that trigger point, see if we can recreate it in the masseter. So if I can push here and recreate a headache in Corey, then there's a good chance that I can help take that away and we can give some exercises to relieve some of those symptoms. So we'll start with just some manual therapy, and generally we'll just kind of manual therapy, real light, just kind of pushing down through this masseter, kind of doing like a little ART myofascial release through this tissue. And we'll try to get Corey just to relax the jaw as best he can as we do this, okay? So we'll go there, just kind of working that masseter, nice and easy. It's very light. And then we will have him open. So we'll have him open, and we usually use a glove for this because I'm going to be on his lower teeth, so I'm going to get him to elongate. He's just going to open as far as he can. This is just a little PIR, post-isometric relaxation stretch technique. So I'm just going to have him close nice and easy, very, very light. We're going to hold that for a few seconds, and then we're just going to relax. Trying to really stretch out that masseter. We'll do that a few times, trying to get this muscle to relax. I'm kind of monitoring the tension and tone with my other hand, and relax. And you'll just feel this basically just melt away. Like all this tension will just relax. And we'll follow that up with protrusion. So we're going to focus more on like the lateral pterygoid, which is responsible for protrusion. So if you think of lateral pterygoid, the jaw goes down. So with that, we're going to come here. So my force is this way, and he's going to protrude. Okay, so I'm still monitoring tension within the jaw, a little push, and then we're just going to relax. And we're just going to try to sink him into the table a little bit. Good. Again. And relax. It's all very, very light. We're not pushing. We don't manipulate this joint. And then we usually finish with a mobilization. So we do manipulate the thoracic spine, the neck, and the back with these conditions, usually because of the component with posture and cervical spine related issues. But then the mobilization, because if this muscle here is responsible for mouth closing, it just constantly compresses that joint. So we need to kind of mobilize and open it up. So we'll just have Corey relax the jaw as best he can. I'm just going to basically place my thumb on the back teeth, okay? Right on the mandible, and we're just going to relax. And I'm just going to kind of feed down toward his feet, nice and easy. You can tell it's pretty light. The hardest thing is to get a patient to relax with this. Good. Corey does a good job. So we're going to mobilize that. And that's kind of how we finish. And we'll do more posture exercises. A lot of times we have inhibition of or weakness in the deep neck flexors, so some of that posture stuff is really going to come in. And then also stress management. We respect the fact that if you're constantly clenching, if you wake up in the morning, we might need to get you a night guard or a bruxism guard because you're just shearing through those teeth and you have way too much tension side to side. Another great relaxation technique is if you put your tongue to the roof of your mouth. It's basically impossible to clench and bear down through here with the tongue to the roof of the mouth. Okay, so that's a quick treatment, kind of what we do here at Omaha Spine and Sport. Anything to add, Corey?
Not really, other than just some common misconceptions about the TMJ and TMD in general. Is that it's a structural thing, and I know there's lots of different ways to go after treatment of the TMJ or TMD, and a lot of times like the old school thoughts were more like shaving teeth off and trying to get like the symmetry of the mouth exactly the way, like perfect from side to side. And we know that asymmetry is the rule in the body. And so we're going at it with just kind of a functional approach. We're looking at posture, we're looking at clenching, stress types of things, and we're going to try to give you some advice and some stress management tools to kind of help you with that, because a big part of TMD and these kind of problems is clenching, and especially at nighttime. So if we need some help, like what Jay said with the guards, like the guards are best done at night versus an all-day splint. Some of the really good research out there by Okeson, who's kind of the authority on this, shows that there's no difference in TMJ or TMD management with an all-day splint versus a nighttime splint. So we just help it along. We work with the dentist the best we can to co-manage this, because there's usually a co-management aspect to this. So if you do suffer from TMD or TMJ or headaches and you've never had it looked at and you're really worried about it because you think somebody's going to be kind of whipping around the joint in the jaw, that's kind of a rough overview of what we do for TMD and TMJ and headaches and those kinds of things when we have somebody present with those symptoms. So if you have questions or you're worried about it, you can visit our website, www.omahaspineandsport.com. We're right next to Mama's Pizza, or you can give us a call. Numbers on the website. So thanks. We'll probably do another condition next week, and we'll try to keep you informed and keep your questions and your concerns and all of those things out front, so that we can be completely open and honest about what we do in here, and hopefully we can help you somewhere down the road. So if you have questions, you can visit us, shoot us an email message to our website, or give us a call. So thank you.
Had a few comments that the sound was bad. We'll try to clean that up for next week. We're kind of always adding stuff. We have a podium now, a stand, so maybe we'll get a mic. So thanks for tuning in.
Thanks.